we're still waiting for, I don't see Jeff or Sean on quite yet. So we'll give it just a few more minutes. Ollie, had you spoken with Jeff today at all?
Sorry, I haven't.
Okay. Because I think just looking at the list of attendees, he is the only person we're waiting for. So I just sent him a quick touch base, but we'll give it maybe another minute and then maybe we'll just get started.
Okay.
Okay, well, we're at about 1:36, so I'm going to go ahead and suggest we get started with the agenda. Um, I don't see that Jeff has signed on to the meeting yet. So, Sean, I'm wondering if you're willing to step in as vice chair and get us started.
Sure, no problem. Welcome everybody to the Innovation Workgroup meeting for September 19th. let's see. Do we have a quorum?
We do. We have yourself, Kimberly, and Tom. So we
Oh
are
yeah, okay.
just there.
Great. Well, in that case, let's approve minutes if we can. Those are attached. Willing to take any motion to approve?
Move to approve.
Thank you, Tom.
I'll second that.
All right. It's a small group, so I'll just say any opposed. I don't, so I think that's all of us. So that's approved then. So I think we're up now for Centers of Excellence. And how much time do we have for this item? So I don't have the agenda and this.
We actually,
Yeah.
Sean, we're going to talk about changes to the work group first.
Oh, changes to the work group first? Okay.
Yeah.
I'm
Yeah.
trying to
So
pull up the agenda
that's okay.
while I'm also looking at all of us at the same time. So
Yeah. Rose, do you think maybe you could toggle back to the agenda for the screen?
oh, that's great.
Yeah, there's just
Oh,
a
yeah, that's great.
couple of items on today's meeting, and there's no attachment for this particular agenda item. I will get us started. Ali, certainly feel free to chime in if you have anything to add. But just in terms of wanted to kind of lay or kind of level set with everyone in terms of where the work group composition is. So first off, I want to say happy anniversary, because this meeting, the September 2003 meeting of the Innovation Work Group, is our official 5th anniversary meeting. The work group first convened September 18th of 2018. So we are like almost 5 years to the day celebrating the anniversary of this work group. So I think congrats to everyone. I want to note that I think by and large, we have had pretty much the same members involved. Maybe a few exceptions, a few folks have changed out over the course of that 5 years, but really consistent engagement over the long haul by all of the participants in this work group. And so I really thank you all for that. That said, to kind of note, we are in a point where we have some changes coming to the work group membership and leadership. First off, JJ Schofield, who is not here today, recently resigned his position with the OEB board, and so along with that, is no longer a participant of the work group. And then secondly, Jeff Brown, his tenure is on the OEB board is coming to a close, and so today was expected to be his last innovation work group meeting. Although, as noted, he hasn't quite signed on yet. I think he probably had a schedule hiccup that's delayed him. So that said, as we look ahead, and so I want to say, even though neither one of them are here, I want to extend, much gratitude to both JJ and Jeff for their engagement and commitment and participation over the past several years. They really have dedicated a lot of time and tireless effort, both in the meetings, but also, behind the scenes, working with staff on strategy and planning for the innovation work group, priority projects and the workflows. So much appreciated. Their input and strategic insight and participation has been really, we couldn't do it. This work group wouldn't exist if we didn't have committed members such as yourselves to drive the work. So definitely want to acknowledge them, and I will do so offline personally to them as well, since neither of them are here right now. But that noted, I want to note so along with those changes, there are some upcoming changes to board membership. There's going to be some new members being onboarded to both boards in the coming weeks. And so we're going to be taking a look at participation in the innovation work group, hopefully recruiting some additional board members participate in the IW. And looking ahead to doing that over the next couple of months, our plan is to have a brief meeting today, share some updates on the Centers of Excellence project, and then adjourn until late fall when we expect to have some of those new members on board and seated. I think at that point in time, when the work group regroups in late fall, we will need to have the work group, by consensus has generally been the approach to affirm chair and vice chair and review and prioritize a work plan for the coming year. So that will all be things that we're looking ahead to once we get into late fall and have a fully seated work group. So I'll pause there. If any work group members or anyone else on the staff wants to add anything or ask any questions, certainly open to that.
This is Tom. Yeah, is there a charter that says it's so many from each board? I know I was added later on, I think mainly because of my involvement at CIAL, but
Yeah, great question. So the charter does say that it will be a minimum of 2 from each board, and that the boards can choose to add beyond that. So that's what we'll want to look to make sure that we have at least 2 participants from each board. I think sometimes, and it's certainly the work group can have some discussion on this. Sometimes there's a lot of value in adding some additional board members beyond that too, if there are participants that are have the capacity and the bandwidth to engage. So I think looking at the charter will be another good thing for us to do once we get the work group reconvened. As noted, it's been 5 years since the work group formed, so it's probably a good time to take a look at the charter and all of the processes. The work group has the latitude to amend or update the charter as needed. So that'll certainly be something that we can do when we reconvene.
Thank you.
Ali, what's up? Yeah.
Thank you, Margaret.
Yeah.
I embarrassed Jeff enough at the end of the last OEB board meeting, but I just wanted to express my thanks as well to JJ and all the time. I mean, you all are high performing board members, and we can't express our gratitude enough. And you really what makes the engine run, and just acknowledging all the OEB members out there, all the employees and their families that have benefited, and the PEB members and families that have benefited from all your time and efforts. Can't be understated. And I also wanted to mention for our PEB board members, Kimberly and Sean, that we'll be having a little celebration for Jeff after the OEB board meeting in a couple weeks. So I will send that invitation. It's in Kaiser, but carriers will get that, as well as Mercer and other previous consultants as well. So
do you know roughly
big
around
celebration.
when?
It'd be 2 weeks from today. I'll send that to you right now, Kimberly.
Okay, thank you.
October 3rd, 3:30 to 5 is what we've got, I believe.
Wonderful. I'll be in town. Perfect. Thank you.
Great.
Yeah, please, if we don't end up seeing them again, please extend our gratitude and thanks as well from us.
For sure.
It's really been great working with both of them. And like, as it so happened, they both at the same time were leaving. So that but it's really been I've learned a lot from both of them. So just really appreciate it.
Do.
All right, any other comments? All right. Thanks for that. And yeah, sort of bittersweet and exciting for new people as well. So we'll stay tuned on that. All right. Let's go ahead and move on to the Centers of Excellence project update. And Marie, I think this is. Yeah, are you taking this one? Your audio, we're not hearing you.
Yeah,
Check your
we can
audio.
see your lips are moving, but we're not hearing sound.
Yeah. This is gonna be me.
Oh, you're good now.
Oh, you're not. Hang on one sec. Wait.
Okay.
Am I good still?
Yeah,
Okay.
we can hear you.
Sorry. Today's presentation is going to be about providing an update to what we did for the what we've done over the last few months on the Centers of Excellence. So we will provide an update on the project plan as well as a couple of meetings that we held with some interested parties and had some interesting conversations. I think some pretty good conversations in those meetings, and we'll provide a little bit of feedback on what was discussed during those calls. So if we move on to the next slide. Thank you. So the project plan here is similar to what we showed before, although we have updated some of the status and some of the dates in this case to, I guess, reflect reality, unfortunately, where, in terms of reviewing the data, we had hoped we would be able to actually start providing some information, I think maybe at this meeting or the following meetings. But unfortunately, we are still having contracting issues. And so we are still trying to finalize the agreement to get the data and to then be able to work with Healthcare Blue Book to essentially analyze that data and provide it, with the metrics and so on and so forth. And as I don't know, Margaret or Ali, if you want to provide any additional comments before I move on.
Sorry. I think you kind of covered it, Emery. Our hope is, I mean, we're working through some of the logistics around data acquisition and analytics, and it is taking a little bit longer than we initially planned. While it's, we're moving as fast as we can, that's not a total surprise, I guess. So again, I think we're moving along and hoping that by the end of the calendar year we have some at least preliminary data to begin to discuss.
Yep.
Didn't we have an agreement? Didn't we have an agreement before? I mean, we've analyzed the data. Is it new data that we're trying to get, so we have to do something different?
So, Tom, I think the data that we had from APAC was actually provided through MODA. So MODA had the agreement with APAC, and we received MODA's,
Fine.
I guess,
so
summarized.
It's a different group that we're working through.
Yes.
I understand. That's all.
Okay, yeah. So it is a different group. We're trying to get access to the actual claims information. That's where the hiccups lie. Actually, can we move back one slide, please, Rose? Thank you. So, as a result of the delay, we've kind of moved back the metrics and scoring. And again, as Margaret mentioned, hopefully we will be able to see something maybe by the end of the year. But the next steps are kind of similar. Just everything's kind of just getting pushed back into 2024, unfortunately. So the metrics and scoring, identifying those facilities, and then making sure we see the gaps and, taking a look and applying it, comparing to what actually has happened. And that member-focused approach in terms of communication, it's going to be continuing as once we, get that additional data. We are still working on, just the best practices on that information focused approach, and those were some of the conversations we had with the interested parties. So hopefully that will, take root and really kind of blossom in the early part of next year. And then phase 2 is on the next slide. Some of the additional, I guess, harder aspects of the COE, it's just the timing's more up in the air as we work through this initial phase 1 step that that's getting pushed back. So, the additional contracting requirements, plan design, and travel benefits, those discussions will happen following. Essentially implementation of phase 1 or during implementation of phase 1, and we can then work on phase 2. So I think that's the update for the project plan. I'll pause here for any questions. Okay. So moving
I'm
on.
sorry, it
Go ahead.
took me a little time to
Yeah,
get
go ahead.
off the mute. So in terms of looking forward for OEB 24-25, do you think we'll be in the first year of implementation for the 24-25 plan year, or do you think we're an additional year back?
Good question. Uh, I don't know if I can definitively answer. I think we will try to shoot for, at least, talking about and having some of the harder aspects of it in the plan design and maybe some contracting stuff at that point if we can get the data in time. But unfortunately, I don't think I can give you any sort of real concrete answer. Ollie?
Yeah, I can provide a brief update. Just I'm working on the APAC data issue, and I don't anticipate it's going to be very long before we get that worked out. I mean, within a couple weeks, hopefully, at the latest.
Because I think we had also though talked about the being a multi-year phase in where we could put just as a starting point, we could have carrots instead of carrots and sticks in round one. We could say to those who are going to our top tier groups, we waive the $500 additional copay, the additional cost tier as an example. So I sure would like to have something for that first year. I mean, for the 24-25, it has been somewhat tortuous.
Yeah.
And Tom, just to note, I think you raise a really good point there in terms of with this phased approach to rollout. There is potential, I think, when we think about 24-25 for OEB and kind of the initial year, to be looking at some of those kind of first level
Yeah, right.
ways to engage members, which would potentially involve, and I don't want to put the cart before the horse, but would potentially involve more subtle, plan design impacts or contract changes that wouldn't necessarily have as long of a runway to implement. So I think that that's potentially sort of the types of approaches we should be thinking about for 24-25, or are those that are sort of the, I guess, lower hanging fruit, so to speak.
Yeah. Okay. I just don't, it's what you can do is you can wait until everything is really rock solid and yet to keep momentum going. If we can do some early stuff, it would be, I think, very helpful. It will show that we mean it.
Yep. Understood. Thank you.
Okay, great.
Thank you.
Thank you.
That's definitely good feedback. Okay. Moving on. So, as mentioned earlier, we had a couple of meetings with interested parties. So, the first one was the one on the left. So, we met with carriers to discuss, communications, really the first step. What could be done to help make this information only phase one more useful. So, helping identify or how the plans can identify those members who might be having surgery and communicating them with them early, basically, the shift left on the OEB, values in this case, just trying to reach them before they get to surgery, supporting them, those members potentially with low intensity interventions that we have discussed in prior meetings and, encouraging, talking with the providers as well, trying to get the providers on board with, intervent those low intensity left lining interventions in this case. the other additional things about, trying to steer those members, provide that information on the higher quality was discussed. And we talked a little bit about, contracting and bundle payments and warranties, but that wasn't really necessarily the focus. We could there were some just kind of questions, additional questions around that were addressed in that meeting. Uh, Another meeting that we held more recently was to talk with the Oregon Association of Orthopedic Surgeons, or OAOS. And what we did was to kind of just introduce OEB and PEB. Tom was on that call. I think Jeff was on the call as well as like Margaret and some other Mercer consultants. We talked about the project goals, timelines, as well as clinical and treatment guidelines. So basically, kind of introducing our concept as well as some of the what we would say, recommending as best practices to get their feedback and buy-in on those items. Next slide, please. So this is just a carryover slide for some of the things that we had talked about, at least in that first meeting. It's like considerations for, information, addressing that with the carriers, providers, and OEB and PEB members. We'll go through this, but some things we had talked about on at least that first call. Next slide. And then what we did was to talk about, what we did was talking about those approaches, and this slide kind of summarizes, I guess, some of the viewpoints and discussions that we had during that call. So kind of going through this, there definitely were opportunities to I guess introduce or to supplement the recommended potential for phase one, where we have early identification, member steerage by information, getting that information out to those members. But what we also found was, that it was not really identifying those who were having surgeries quite. That process wasn't, I don't know if it's well defined, but it's just like doesn't always happen, I guess, in that case. There were definitely some, through prior authorizations, but we don't the pre-identification and just getting that access and understanding who's going to have the surgery doesn't always happen, and that redirection or at least information might not be provided. There need to be some work to help do that. One plan did have recommendations on how to redirect potentially members, or at least in their medical policy, directions on how to potentially assess whether it could be done at a lower cost setting, whether it's outpatient or in the facility. Others do rely on the providers to make the decisions, to really manage that member's care. There are definitely treatment decision resources out there, but members generally need to go and find it or know where they are. And when they get those access to those treatment guide decisions, maybe they're already ready for surgery. And so, that early intervention, that shifting left might not quite happen in this case. Referrals, I think there's some discussions about that. A lot of, I think, what we were thinking about in terms of individual preference or availability is what's happening now. So using quality standards might be a difference in different process. And so, we would need to, if we were to try to implement something that's a little bit more information driven, there would need to be changes to do that. As well as, that bullet following that, the quality of the providers. It's not necessarily out there, so what we're doing in terms of trying to identify or potentially, say which facilities or providers might have better quality results is going to be different. And it's not necessarily out there for members or providers to take a look at. And then the final bullet was kind of, I think, I don't know if it's necessarily the biggest aha, but it was definitely one where we're like, it's the physical therapists. It's not just the primary care physicians or the surgeons, but maybe also, talking to the physical therapists and getting them to getting them involved in the decision. So that's another touch point that I think, interested party that we may want to really potentially somehow, talk to, address, to help with this information only approach. And with that, I think I will actually, I think some of Margaret or anyone else from Mercer that were on the call, if you have any other additional comments about it, before I open up for questions.
No, I think thanks, Emery. I think kind of the overall maybe high level is that, carriers are doing various activities in these arenas, but it seems like there's some opportunity to maybe further develop the approaches and standardize. I think it was noted that, in some cases, it seems like maybe there's an opportunity to do some of that early identification a little bit earlier in the process. So thinking about the places where that could happen, as Emery noted, I think physical therapy was definitely identified as a potential access point to members who may be on the pathway to surgery. Yeah, so and as Emery noted, I think I think we've really touched on before as a group that when it comes to provider quality information out there, there really isn't much for a member or potentially a referring provider to really rely on. So it seems like there's opportunity.
Thank you, Margaret. Any questions or further comments about this meeting with the plans and carriers? Okay. Moving on to the next meeting. So the OAOS, the orthopedic surgeons meeting. So that was held relatively recently. I think it was last week. And Tom, I will definitely ask you for your feedback on the meeting. But it was definitely an interesting, I think, a good meeting in that there was definitely a lot of good discussion. They were that first point. I think at the very top, they were definitely seemed like they were supportive and understanding of the COE concept, and they were interested in partnering in terms of the COE, the approach, and they were saying it was something that they were definitely interested in and had some positive statements about that. That said, they were very interested in essentially the fourth aim of the quadruple aim, just making sure that the providers aren't, too burdened with, what we're asking of them, that we shouldn't necessarily reinvent the wheel, that there were a lot of metrics, there on the third bullet. There's a lot of metrics out there, a lot of requirements, the joint replacement registry, DNV healthcare, joint commissions, commission, CMS. Those were some of the, metrics that were brought up, and that they suggested that we look at those and align the metrics to make sure, that there isn't this too much of a burden put on the providers to ensure, to demonstrate quality or to ensure that quality is being provided. They were definitely interested or concerned about rural access providers in rural areas and health system capacity. Some of the things that we are as a board, IWG, have been aware of and are considering. And they did provide some interesting comments about some of our best practices. One was in terms of we had talked about 12 weeks of physical therapy as a potential early requirement, or as a way early intervention, and that not everybody may be wanting to do physical therapy, and to consider other members who may be just exercising already, to have that part of it, or that the cost of physical therapy may be onerous for some of these members as well. So I think that was some interesting, good feedback as well. And then further discussions with them, reviewing the quality measures that we're going to do, providing some feedback, and just ensuring that when we do measure and talk about which providers are quality, that everybody's on board with all of the metrics and the understanding of what we're saying would be quality, and agreement on those metrics defining quality. And with that, I will actually ask, Tom, you were definitely very involved in that conversation as well as Dr. Prachunatha. But Tom, do you have any feedback?
The it was a bit of, um, yes, they're interested and thought it was a good idea, and yet it sounded like they thought that it was Lake Wobegon where all the kids were above average, and there was not a clear understanding that there may be gaps in care, and obviously the orthopedist from OHSU who ended up rattling off the various registries and things like that. There may be data that's being collected. I haven't seen it. I'm not sure if it's being used in any way. And if there are metrics, one of the follow-up questions for them is, okay, so and how's this data being used? And we need to find it and make sure that what we're measuring is in sync with what they are what they're measuring. So no question about that. The issue around rural, we don't know the data yet, but it's possible that, let's just assume that that the quality of care is, when it's risk adjusted and everything is lower in the rural environment, because they don't have the same sophistication or coordinated teams and the like. Just assume that. I don't know if it's true or not, but if it was, then there's this issue of, okay, the importance of preserving access for rural providers because they provide not as comprehensive care. I mean, there's some real conundrums there. It was a bit of circling the wagons, appropriately so. I mean, it's exactly what you'd expect. So I think we need to utilize and you really said that you wanted to participate and you agreed with the concept. This is what we're working on, but if we get a whole lot of pushback, it will need to be circling back. But you agreed to to the concept and things like that. So this was a critical meeting. They need to know what we're doing because they could really work as a group, could work really hard at sabotaging it. We need to make sure that our metrics are in sync with theirs. And then we need to continue to move forward. There were some important points around, as you described, the physical therapy part. Probably the most important part is going to be around the criteria that people need to meet for them to have elective surgeries, because that's where if I remember from 20 years ago, there was a study that was done at Kaiser Permanente across all the regions, so thousands of cases, and they looked at knee replacement outcomes, and in infection rates was an order of magnitude higher, and infections in artificial joints are disastrous, but there was a order of magnitude increase in infection when people had surgery with BMIs greater than 40. And that's going to be also because they have increased risk of diabetes and a lot of other technical things. But the most important, the bang for the buck in terms of improving this, of working on this, is going to be making sure that the kind of the entry criteria are the ones that are being managed. And we'll see, we'll kind of circle back and say, we'll get our metrics in sync and make sure that all of that's there. And I think we'll need to be then going back from that, the entry criteria.
Yeah, and
Margaret, you were there. Prachi, you did a lot of the conversation. Prachi, I'm interested in your thoughts.
yeah. I mean, I'd say it was one of the many conversations, right, that we had with them, and as an initial one, a part of me was happy that they were aware of the concept and were already on board of a version of the concept. I'll say a version because centers of excellence in the full capacity, right, would have bundle payments, warranties, etc. So we don't know what some of the models they have been working with, but in general, the concept of steering care towards higher quality providers, that was something that they were aligned on. And I think the devil in the detail will be, how do we define that? And that is what they were looking to get into at that call, which I know we will be getting back to them on, which is our quality metrics. So I think that is a good follow-up, and that would be a critical one, Tom, to your point. Then once they agree to that being the quality criteria, then to go back and say, hey, you agreed to the quality criteria, now here is the outcome, right? But I think so that will be something where we would need to be as close to some of the industry standards and best practices, right? They were aligned on identifying who would be the right patient, right? They're like, yeah, we know hemoglobin is important, we know all of some of those things, although I don't know, they didn't want to record it, but it is already in the charts, right? So I think one important part that came out of that was also the involvement of the PCP that was mentioned in the chat, and how do they integrate with helping the patients getting to that right optimal health status level. So I think that would be important as we look at, how do we create those processes in place. But all in all, I think it was a good first discussion, and the next one will be all the more critical when we go back to them with some of the quality metrics. But
yeah, the only thing that we haven't talked about that meeting, but we've had some conversation at IWG, has to do with what is the capacity situation for the state. The issue of what would happen if we did something that took half of the capacity away from the system. Well, probably disaster, because it looked like the sense was everybody was had months-long waits to be able to get surgeries. Now, if you decrease the number of surgeries, that may change, but the current system is pretty bottled up, and that is for multiple reasons. Again, the orthopedist from OHSU talked about she is now 70% as effective as she was pre-COVID, just because of all the additional things that happened regards to COVID. So it just shows this is a real complex area, and we're going to need to be very thoughtful, and there'll be more conversations.
Yeah. Jeff, you have your hand up.
I think you're on mute.
Can you hear me now?
Yes.
Did someone mention before that the doctors were advocating for an Oregon-based program?
We did not discuss that.
Okay.
I think
We
when
never,
when
we, Jeff, yeah, we never said that we were actually looking for something other than an Oregon-based
yeah.
solution.
True,
And-
but
and-
there
And
was
Tom,
a statement advocating for that.
Yeah. Tom, I
Yeah.
do recall that you at one point shared that, part of the work groups, you talked a little bit about the statutory cost growth cap on PEB and
Yes.
OEB and sort of the
Yes,
the
reason
factors,
why.
the catalyst behind this. And you did, as part of that, mention that, we also don't want to be looking at a situation where we're sending our members far from home, sending people out of state for services. So we didn't have a prolonged conversation about the notion of an Oregon-based program, but we did talk about wanting to develop something locally. There was also some conversation around when we talked about the rural access concerns. We did get a little bit into our approach of looking at geographic regions and trying to identify COE providers in each of the regions so that there would be statewide coverage to some degree. So yeah, I don't think we had a belabored or long conversation about it being Oregon-based, but we definitely did share some of the thinking behind it and the desire to not be sending members out of state.
Another comment that was made is would like to see some provision for more direct access when it's an obvious case. And I'm not quite sure I'm saying it the way you did, but if we're advocating step therapy, said, well, in general, I'm in favor of that. But if it's obvious, why do we want to put them through the pain and the expense? So in the design, there needs to be an appeals process, which I presume would already be there, but make sure that that's clear.
Yeah. And yet the problem with that, Jeff, is the outcome, how well people do post joint replacement surgery is if you go in, yes, you really need it, but you haven't had the physical, the exercise program / physical therapy. You take months and months and months before you get better. So it's this weird, yes, you really need the surgery and it's keeping you from working. And yet if you have surgery before building up the muscle mass, you then are months and months after surgery before you're able to get back. So it's just, again, this is a real complex area, and we'll look
Absolutely. I mean, what kind of shape is the patient in going in?
Yeah, that's hugely important.
Requiring saying, BMI's too much and you're a fairly sedentary person. We need you to go through the exercise program. But so it's, just allowing for some flexibility in how we approach it.
Yeah. And definitely, Jeff, to your point, I think part of the conversation from the other meeting with the plans and internally, actually, we were talking about this. It's, who are the people who really know whether someone's ready for surgery? Like, is it, the physical therapists are kind of there as, some of the people have been working with the physical therapist, and they know whether you might have to have that surgery or not, or whether physical therapy is working for you. I think that's, definitely an important touch point in this entire process. It's like, some people definitely are ready for it, and maybe their BMI and all the other conditions are ready for it. Some people may not and need help getting there. Just making sure we can address all of the members, appropriately at the right time. And as we might not be able to get everyone, but I think we can try to get as many good guidelines out there as possible, as well as getting that information out to those members as well. Prachi, did you have something you wanted to ask?
Yeah, I just one other thing also, again, this is not a mandatory program, right? Where we say you must do all these things. Obviously there is going to be clinical judgment, but it is going to be outcome based, right? So focus, I think, is not on surgery avoidance or anything. And I think we talked about that at that meeting as well. The focus is going to be on, routing patients essentially to the right provider or the higher quality provider and and most importantly on the outcomes, right? So the quality of life post surgery, and if you're getting it, or if you're doing PT, then you're recovering post PT, right? So I think that is something we need to keep reiterating, that the focus is probably is for the most part going to be focused on the outcomes.
Yeah, agreed.
Any other comments or questions? Yeah, so we don't have a next step slides, but I think continuing that conversation with OAOS and the plans as well, all interested parties, but making sure we get those quality metrics back to them, getting the feedback and going back and forth, and just kind of taking a look again at some of those other metrics that were provided or referred to by the OAOS, getting that to them, as well as working on, as Ali was hopefully getting us the information, getting that, getting the data, and then being able to run the quality metrics to really do phase 1 of this properly, to implement it. And then once we do get that, then hopefully we can come up with those quality metrics, the ranking of the facilities, have more conversations with all of the parties about, those rankings, and the boards, and as well, and taking that to potentially move into the next step, which, as Tom had mentioned, potentially a very kind of a soft, I guess, launch of some of the plan designs, where it's more carrot than stick, or just all carrot. I don't know. That's, I guess, we're talking physical therapy and staying healthy, so we'll stick with carrot. So I think that's really where we're going to hopefully be, and be able to progress as we move on. But with that, I think that's actually our presentation. So I will, unless there's any last questions, comments, I will turn it back over to our chair, Jeff.
And I'll punt to Margaret, since I'm late in coming to the dance.
You bet. And I actually, Jeff, I had Sean filling in for you. But I won't punt to him, because we are close to the end of our agenda. As was noted at the beginning of this meeting, this is a short one today. So the only other agenda item that we have is public comment. Just want to check in with Rose if we have any. I'm not aware of any.
No, there's no public comment.
Okay. Great. Thank you, Rose.
Uh-huh.
So that said, we are ready to wrap up and adjourn. As I mentioned, the Innovation Workgroup is not going to be meeting in October. October 17th would be our regular meeting day. The PEB board is having a longer meeting on that day, so they're going to be taking up much of this afternoon time slot. And as previously noted, we've got some transition in the work group with bringing, identifying and bringing new members aboard. So that said, I think we're ready to adjourn. Before we do, I just want to take 1 minute, Jeff, and say thank you to you. We actually were singing your praises at the beginning of this meeting, and I know you had a little bit of a delay getting here, so you're going to have to listen to them one more time. But thank you so much for all of your engagement and just participation in the work group. I don't know if you realize this, but I mentioned earlier, this is our 5-year anniversary of the Innovation Work Group. So the group launched September of 2018. And I can count probably on less than a couple fingers the number of meetings you've missed in that time. So you have just been made yourself really available and very engaged, and have just always been really collaborative and a good strategy partner for this group. So I think, as Ali said, earlier in the meeting, we could not do it without board members like yourself. So thank you so much.
Well, thank you. Thank you very much. Tom is going to chair going forward, and you couldn't be in better hands.
I'm not. I don't know if I'm not sure for the IWG.
Yeah. Well, yeah. I think the plan is that once we get a couple more members identified, we will have the work group confirm their chair. I know Tom is
I'm gonna keep on the group though, Jeff.
Yeah.
I'm gonna keep the Jeff Brown drive spirit going.
Well,
I'm gonna
Yeah,
channel you.
Well, and Tom, you are definitely a seasoned and experienced group member. So I don't know that anyone will challenge you for the chair.
There might be some carrots in it for you, Tom.
Yeah, exactly.
Right.
Well, thank you all for your hard work as well. There's been a lot of effort that's gone into this group, and it's kind of something new that, we've had our struggles, but we've also had our victories. So thank you.
Yeah.
Really
Signing
appreciate
off.
working with you.
Huzzah, huzzah.
Yeah.
All right. Well, thanks everyone, and we will reconvene later in the fall.
Bye, you
See you in
guys.
November.
Be
Bye
safe.
now.
Bye-bye.
Thank you.